Well, I'm very happy to be talking to the International Society of Psychiatric Genetics. I haven't been to this meeting in a few years, and I certainly didn't expect to be going to this meeting in my study in New York City. But maybe next year we will meet in person. I'm going to talk about the studies I've done in translational epidemiology, studying families at risk for depression, and I hope this has some relevance to those of you who are interested in genetics. The next is my disclosure. I certainly don't make a lot of money from any of these, and they have nothing to do much with my talk, but here it goes. What I'm going to talk today is about translational epidemiology, and I'm going to try to show you how the bench, the population, and the bedside are all intermingled, and they're intermingled in the context of an intergenerational study. When I began this work right out of graduate school, can you believe that the question was, does childhood or adolescent depression exist? And a very prestigious group at NIH had a meeting to discuss this issue. And the conventional wisdom held that major depression was a disorder primarily of middle-aged and menopausal women and didn't occur in children because they didn't have sufficient ego development. The meeting concluded, and this was 1978, that the notion of a syndrome of childhood depression rests largely on surmise. Well, next came the data. In the 1980s, now this is a later slide from 2019, but this is exactly what was found in the first epidemiologic study of psychiatric disorders in the United States. And that was the epidemiologic catchment area study. And lo and behold, it found that the age of onset for depression began in adolescence around 11 to 15 and started to peak around young adulthood, 16 to 21. And in fact, first onsets, we're not talking about recurrence, but first onsets after the age of 50 were very uncommon. It was these data that led me to start looking at families at high risk for depression, because I argued that if you wanted to study the first onset of depression, you should get people or offspring who are at high risk. And we knew from the genetic studies and the family studies that you were at high risk for depression if you had a family member, which we called generation one, your parents, who had a major depression. So that's how I started this study. We began with generation one who had a serious major depression. And then we chose somebody from the same epidemiologic study in the same community, this was New Haven, Connecticut, who on 3 occasions had no evidence of any psychiatric illness. And we did a few interviews to make sure. We began by studying their offspring, generation 2, and as expected, generation 2 got married and they had generation 3. We have just started a study of generation 4, the grandchildren, the great-grandchildren. And we used the same methods in the high and the low-risk families, and the interviewers didn't know if the person they were interviewing was from a high or a low-risk family. Now, why did we bother with this? For a study that is intergenerational and longitudinal, you can get a lot of bang for your buck. First of all, you can see the early signs and symptoms of a disorder as the person begins to emerge with symptoms as you follow them through time. You can really see the age of onset and the clinical course of the disorder, not just having a person retrospectively telling you, but you can actually see it. And this, of course, is very important for biological studies because you can see whether the biological traits occurred before the illness, and then we differentiate a trait from a state. And finally, we can determine resilience. Who of the high-risk individuals with the trait but not the disorder are resilient and don't develop the disorder. So an intergenerational longitudinal study seemed like a very good way to spend one's research time, and that's what I did. And here's what we found, and I won't bore you with the rates at 10 years, 20 years, 25 years. These are the rates at 30 years. That the low risk is orange, the high risk is blue. And as you can see, for every one of the disorders, except schizophrenia, the rates of major depression, of anxiety disorder, of any substance abuse were higher in the high risk than in the low risk. We found very, very few cases, I think one or two, of schizophrenia. And we found very little bipolar disorder, I think only one or two cases. So this is, again, an example of a clinical study. Next. And this shows you the age-specific rates of depression in the offspring by high and low risk. In other words, when does it first start? And you can see that this parallels the studies from the epidemiologic surveys. In other words, in both the high risk and in the low risk group, the age of onset is mostly in adolescence and young adulthood. And after the age of 40, there are very few onsets. And the rates are higher in the high risk group, but the findings are very similar. There's only one difference, and that is the prepubertal onset. If you look at the onsets between the ages of 10 and of 0 and 10, the prepubes, those only occurred in the high risk group. And we've later learned that prepubertal onset depression is rather uncommon, and mostly it was found, I think almost exclusively, in the high risk group. Now, that doesn't mean that there aren't disorders in prepubes, but those are mostly anxiety disorders. Now, this was one of our a very distressing finding, and that had to do with mortality. The mortality rates were much higher in the high risk group, and at this point, the group was in their early 50s. And you can see the rates of 6.6% versus 2.5%. But this is exclusively accounted for by deaths from unnatural causes. Those are suicides, accidents, and overdoses. Now, we weren't sure sometimes whether an overdose was deliberate or not, so we called these all unnatural causes. And you can see that the mean age of death is much younger in the high than in the low risk group. Now we're looking at the 40-year findings right now, and this has been maintained. And in fact, the deaths from unnatural causes in the high risk group have doubled, and there are no deaths from unnatural causes in the low risk group. So what about the grandchildren? And this is the main finding, I think, for the grandchildren. You can see here, by the time we get to the grandchildren, we have the grandparents, that's generation 1, and some of them weren't depressed, that's low risk. Some of them were depressed, that's high risk. And then the parents, generation 2, and again, some were depressed and some weren't. And these are lifetime serious depressions. And here we see the grandchildren. Fortunately, most of them have escaped from depression. Now here, they're only about age 18, and we're following up them. Now they'll be around age 28. But look what we find. Those grandchildren with 2 previous depressions in generation 1 and 2 have very high rates of mood disorders and depression. They're almost double the rates. And this finding now has been replicated in a very large Scandinavian study. And we've been looking at it in the ABCD study that is a large data set, and we're finding the same thing. We're very interested in looking at the relationship between our boutique studies, where we've interviewed everybody and we've had best estimate diagnoses and a clinician looked over the diagnoses, but the samples are small. And the large studies, the big data studies, which are now emerging, have not such clean data. The information is from family history, self-reports. They're not direct interviews, except for the offspring are directly interviewed. So we have large samples and we have heterogeneous samples. And what we're trying to do is to see whether our boutique studies and our findings are replicated in these large data sets. And I think that's extraordinarily good use of both types of data. So what have we found? just to summarize. The offspring of depressed parents, mean age here was 48, have an increased rate of depression. The onset is usually in adolescence. It's usually before the age of 40. They have more recurrences, more impairment, more divorce, more treatment seeking. I haven't shown you all of that, but it's all published if anyone's interested. And they have increased mortality from unnatural causes. The grandchildren, age 18, with 2 previous generations affected, have a 3-fold increased rate of depression. They also have an increased risk of suicidal behavior. And that now, as we're following them, it's about 8 or 10 years later, we're seeing more of that emerging. These findings are holding up. In the analysis we're doing right now, we're asking a question, do the low-risk group catch up? In other words, the high risk may have their depressions when they're young, but maybe the low risk have it when they are older. And that's not what we're finding. Nor are we finding increased mortality from unnatural causes in the low risk. In fact, the high risk group tends to be just what we found earlier, more impaired, more depression, and more problems. Well, about halfway through this study, I said, well, what are we going to be doing for these people other than studying them? Shouldn't we see if we can modify the risks? We can't modify their parents, but we could treat their parents. And just by accident, getting stuck at an airport in Hawaii with the Maurizio Fava, who was head of the STAR-D study, the huge study of 4,000 people to see whether you could prevent recurrence of depression by active treatment. I started to talk about my interests, and he told me about STAR-D, and we concocted a study, and we did it. The mothers in STAR-D were receiving treatment as part of the STAR-D, which is Sequenced Treatment Alternatives for the Relief of Depression, 14 sites across the United States, and to try to understand what to do next if the first treatment doesn't produce a remission. How do you keep a mother or father into remission? And this is an example, if you look at the bottom, of going from the clinical to the bedside. I won't go into all the details, they're all published, but we found that mother's depression is a modifiable risk factor with successful treatment. Does it help her children? And after 3 months of treatment, we found indeed. If the mother remitted, the child got better. That's percent of children with a diagnosis, the white bar. And if the mother didn't remit, the children didn't get better. In fact, they got slightly worse. Now, these were treatments all with medication. I think it was sertraline was the first treatment that was used, but these mothers were all on medication. And we actually replicated this in another study, again, where we use medication. But this work has been replicated by the Pittsburgh group, Holly Schwartz, using psychotherapy. So I think the big message is get the mother better if she has children. If medication works, fine. If psychotherapy works, fine. If winning the lottery works, fine too. But get her asymptomatic because her children will get better. Now, there were a lot of other findings, and I just summarized them. I think we can say strongly from the 3 studies, 2 of mine, Holly Schwartz, and actually a 4th study, Nancy Grody, in Seattle, a child's improvement significantly was associated with the mother's remission from depression. In our study, if the mothers remitted in the first 3 to 6 months, the early ones, that was the most positive outcome. But even if she remitted later, the child remitted, although fewer of them remitted. And the child's clinical status was retained for 1 year after mother's remission. We didn't have any money to follow them afterwards. And I think we can say that mother's improvement, regardless of the type of treatment, helps the child. So that is a very strong message for reducing symptoms. Now, we did a number of biological studies, so my population bench to bedside is missing the bench because I don't have time to present it, and also the biological studies, which are with MRI and EEG, are best done by the people who are the experts in those studies. But we did find some abnormalities in cortical thinning that were related to being in the high-risk group, independent of whether the person got depressed. But I'll end with this work, which was done because of our interest in moving younger and also looking at in utero exposure to SSRIs, because SSRIs are so frequently recommended for treatment of depression during pregnancy. Now, I worked with Jay Gingrich and Marcus Harnage, and they showed that exposure to SSRIs during the sensitive developmental periods in rodents produce long-lasting effects on behavior and neural circuitry by early adolescence. Wow. And because serotonin system is highly conserved across species, we suspected that similar effects might be seen in humans, as SSRIs pass readily through the placenta and enter the fetal circulation. And as I mentioned, they are prescribed increasingly for pregnant women. When we began this study, there were no studies that had followed SSRIs exposed offspring beyond 6 years of age. And our findings, the mice findings, not ours, were in early adolescence. So we hypothesized that we might not see the findings right at birth, but we might see them later as the child entered adolescence. And we formed a collaboration with Sanders and Alan Brown and Nelm in Finland, who had this large Finnish birth cohort, nearly 18,000 people, and they had good data on whether there was SSRI exposure, and we were able to follow the offspring up to age 14. The findings were exactly as we had predicted. As you can see, that if the offspring was exposed to the SSRIs, the rates of psychiatric disorders starting around age 12 to 14 were high. And if there was no SSRIs, there were no psychiatric disorders, and it follows somewhat in between. So one study doesn't make a definite finding, and you can have lots of discussions about observational studies, and they can be confounded. And we've gone through all of the reasons why this might not be true. So this is, I think, the last slide. These are the next steps. We're following offspring through the age of risk into adulthood in Finland, because the ones we had were only up to age 14. Lahti is going to see if these findings can be replicated in Denmark and in the Mayo Clinic. And the Mayo Clinic, he has actually a clinical sample. And then Jonathan Posner, Lahti, Larissa Tetskar in Sherbrooke are trying to understand the early biological mechanisms of SSRI exposure, and they will be doing imaging studies in EEG on the offspring as they're born. So this work is ongoing, and we hope we have an answer to it soon. So just to end, I've given you a little snippet of how we try to move between population, clinical, bench, and bedside, and there's no one-way direction that's the right way. And I like this statement from Michael Rudder and Plomin, that it would be a great mistake to see translation simply in terms of applying at the bedside the findings of basic science. Many of the pathways start with clinical or epidemiologic studies and not with basic science, and an even greater proportion involve a very complex iteration and interplay between the two. And that's been the substance of the research that we've been trying to do over the years. Some of the team that have been involved in these studies, and these are some of the people who have supported our studies over the years, for which we are very grateful. Thank you.